Hello, and welcome to POMA Does, a podcast produced by the Pennsylvania Osteopathic Medical Association. We provide a voice for osteopathic medicine and share insights on issues important to osteopathic physicians, residents, and students, as well as those who embrace the osteopathic philosophy. POMA's mission is to promote the distinctive philosophy and practice of osteopathic medicine for our patients, our members, and the communities we serve. Thanks for tuning in.
Welcome to POMA Does, a podcast series with the POMA. I'm here today with Benjamin Chack, DO, otolaryngologist, who is also the former president of the Quality Alliance ACO and is an adjunct instructor for population health at Jefferson Health. We're here today to talk about population health. Thank you for coming today. Tell us basically what is population health and why is it necessary?
Well, population health is a concept that grew out of a paper that was written in 2003 by David Kindick, who was a physician, and Greg Stoddard, who's a sociologist. And what they talked about was population health, and they actually defined it as the health and outcomes of groups of individuals, including the distribution of such outcomes within a group. That's a lot of verbiage, but the bottom line is, I think as we progressed into the 21st century, we started to look at outcomes for patients. And the idea was how we could do better in terms of serving our patients, and also how we could start managing the population for better health. Basically, what we were trying to do is figure out ways to treat patients. The basic idea was how we could manage populations and how we could also make them healthier. I think a key component of population health is preventive medicine. And we've come to realize that over the years, I do think that we have had the impetus to start going in this direction. And the reason I say that is we started to have guidelines for things like mammograms, colonoscopies, and things of that sort, but no one ever put them into a more succinct kind of idea of what to do with the patients. And population health brings that under one umbrella. The problem, I think, with the term population health, unfortunately, is that nobody really goes into the doctor's office and explains what we're trying to do. Unfortunately, we spend a lot of time talking about metrics. We spend a lot of time talking about value-based contracting, but nobody really gets down to what the theory behind what we're doing is.
Or what we need to do to make that happen as well.
Yes, because we only had a very short period of time with physicians. Obviously, they're busy and everybody's doing what they need to do to care for their patients. So we don't really have the real theory behind what we're doing. This is not a new idea. This is not a new idea at all in medicine, trying to manage the patients. We've all done that for years. The difference is we're now doing it under this umbrella term of population health.
Aside from better care for the patients, why else should the doctors be concerned about this?
Well, fortunately or unfortunately, and that's kind of the world we all live in, this has become attached to payment, which is one of the issues always in healthcare nowadays. And initially, the term population health, as defined in 2003, was further brought into the realm of medicine by the Institute for Health Improvement when in 2008 they proposed this concept we call the triple aim. And the triple aim, one of the three pieces of it was population health, but they also brought the idea of the experience of care, and the per capita cost was the third leg of this. And what this basically did was try to pull everybody under one concept. That is, when I say everybody, all the stakeholders, physicians, non-physicians, hospitals, payers. So what's happened in the world is that the payers have sort of taken the lead on this, and they have put together programs to hit certain metrics and have certain quality control, so to speak, in order to get payment. And the theory over the years has been that value-based payments would increase. While it's true they still have stagnated to some extent over the last several years to where they're pretty stagnant at this point. So the importance to the physician is, yes, it's great to take care of your patients, and that's what we're really all about, physicians, is all clinicians. But the reality is it does somehow come into the amount of revenue that's generated by a practice every year.
And this can be very beneficial to the practices from a revenue standpoint.
The answer is yes, it can be, because there are different different programs out there, and they all have basic metrics, what we refer to as the HEDIS metrics. People are familiar with that term, and they don't vary that much. So if you really think about it, if you practice doing all these metrics and you somehow have organized your workflows into that, then you're able to hit those metrics. And if you are in these programs, you should get some compensation for it. And actually, in some practices, some physicians have become so skilled at it that it becomes a big portion of the revenue that they make each year in their practice, aside from their fee-for-service payments.
So it can be very beneficial to the practice's bottom line, in addition to providing good care. I know many of the insurance companies have different requirements. So many times we would just do the requirements regardless of the insurance companies so that we would cover everything and not miss one by one company or another. It made it easier to follow. But where do you see this going?
Well, interestingly enough, one of the biggest proponents behind this has been the federal government. They were the ones who initially funded what we called the pioneer ACOs, which were the trial ACOs back at the end of the 2000s. And in the Affordable Care Act, there was provisions made for the ACOs, the expansion of the ACO program. I do think that as time goes on, there will be more funding, more pressure to go into this type of scenario. The ACOs themselves have saved a significant amount of income. The question is, have they really improved the quality? And that's something that's going to take generations to actually figure out. We all know that's an evolutionary thing. It's not revolutionary. CMS, by the end of this decade, wants every fee-for-service Medicare patient into some sort of an ACO program. Their belief is that will decrease cost and improve quality. I do think that there will be increasing numbers of patients in these programs through Medicare Advantage programs as well, because again, they're an extension of the federal programs. And there are also a number of Medicaid ACOs which have formed and are expanding. I do think that over the next 10 years, you will see more value-based payments coming through, and they will be more important to the practices, to the providers in terms of managing their revenue.
So what are ACOs specifically?
So ACOs, as I mentioned a few minutes ago, the term is accountable care organizations. And the idea was that if you got a group of physicians together and they managed the population and they did it in a graded fashion, in other words, that they were able to manage the patients almost like a group practice without walls kind of thing, that would reduce care, the cost of care, and improve the quality of care. The federal government in the Affordable Care Act, as I mentioned a few minutes ago, made provisions for it. And essentially what we do is we take a group of physicians, mostly primary care physicians, and we create a population. And in that population, we try to manage their metrics. And if you're able to bring the cost of care down, that income is shared with the ACO, and it's paid back to the physicians. Interestingly enough, the federal government has specific criteria on how these are to be run. They have to have a certain threshold of number of patients to spread around the risk, so to speak, of the patient costs, but they also have to be managed by physicians. The boards have to be a certain percentage physicians. There has to be a non-conflicted Medicare recipient on the board who basically is able to tell the story of what it's like to be a Medicare recipient to these physicians on the board. The whole concept is really to bring the groups together to try to manage the patients in a more efficient way.
Do you think this will be the evolution from MIPS eventually, or is that going to be a continuing running thing where we're actually doing metrics for two different groups?
Well, currently, if you're in an accountable care organization, the Medicare Shared Savings Program, you are MIPS exempt. So one of the benefits for the physician is he does not have to do his own reporting. So when group reporting comes through at the end of the year or the beginning of the following business year, the physician himself is not reporting on his own. If he's in an ACO, he's covered. He may be asked to produce some charts for audit, but certainly not the degree of involvement that it takes to do MIPS. And you're right, Ange. If the government gets to the point where every patient is in an ACO, MIPS, in theory, at least for primary care, should go away.
That's where it seems to all fall, is onto primary care. And, a lot of people look at it as, I have one more thing I have to do. So, having it all streamlined would be a big benefit to everybody. Are there any tricks to making it more efficient?
Well, I think there are two things that help. And I think one is the concept. You kind of mentioned this, and this was one of my ideas, my mantra, so to speak, going back almost 15 years when I started with this, is you want everybody to do everything the same. So you want to make sure everybody has a colonoscopy, everyone has their mammogram if it's indicated, that they have their vaccines and so forth, because then you're not jumping from one group of metrics to another, because they can vary from contract to contract a little bit. So if you get into that regimented workflow, then I think it's very helpful in getting through your day. The second thing is your EHR, and this is sort of everybody's bugaboo, so to speak. Some do it really well and some do it really poorly. If you have an EHR that does it really well and you have like a health maintenance tab, like some of them do, you will see what's deficient in the patient's studies for the year, or for the whatever it is, if it's A1C you're managing or so forth. So I think that it's very dependent to some extent on what system you're working in. If you're working in a very good system, your life's a lot easier. If you're working in a system that's unfortunately sort of one of these systems that's not really good for practice management, maybe was a converted hospital system for practice management, it might be more challenging.
Yes, with a good staff for support, then it really makes the flow of this much, much easier.
When I was working in the Health Alliance, while we spoke a lot with the physicians, we spent a lot of time with the staff. You need champions inside the office. You need the office manager to understand what you're doing, the benefits of it. And then, this does significantly impacted by your medical assistant. We taught them to do pre-visit planning so that it wasn't the physician's job. And in the early days, we had a lot of practices on paper, and we had devised paper checklists, basically put in the front of the charts, and we taught the medical assistants to do planning. So they would go in and check off what was not done, and the physician, when he did his visit, would go through those metrics that need to be fulfilled. Staffing is the key here. And unfortunately, I believe that as we've gotten ratcheted down in healthcare, staffing for the physician has suffered over the last 10 to 15 years. Everyone's trying to make it further on a smaller dollar, and a lot of the ancillary staff doesn't get replaced. They don't necessarily let go, but they don't get replaced.
Unfortunately, a good staff member who's well-versed in population health can add significantly to the bottom line of the practice and be much more valuable than their salary to the practice, in addition to, meeting all the metrics and having the, patients really healthier in the long run.
Well, I think at the end of the day, the goal here is to get the patients healthier in the long run, and to try and make sure that if they do have a disease, it's detected earlier. And I think that's what this is really all about. Yeah, I think we can, put window dressing on it and talk about it in terms of value, in terms of dollars, because unfortunately that's where a lot of things go in this world in general. But I think at the end of the day, the concept here is early detection, early treatment, the patient having a better life, even if they have a disease, intervening when it's in their disease process. We all know that earlier cancers do better than late-stage cancers. It goes that way for everything. I think that's the root of what this is really all about.
In other words, it's quality of life that makes the biggest difference in the long run, and trying to improve that.
Yep. I think that trying to keep the patients as healthy as possible, which gives them a better lifestyle, is the key to all of this.
Well, this was very interesting today and very informative. I'd like to thank you for providing us with this information today, Dr. Chack. Is there anything else you'd like to say before we finish today?
First, I'd like to thank you for inviting me to do this. I really wanted to maybe talk like we did about the theory behind population health and what the basis of it is, aside from all the mechanics of it that we live with every day. But I really think this is going to be the wave of the future. I think that we are going to be measured in medicine, whether it's directly as physicians or hospitals or whatever providers they are, like nursing homes, by our outcomes. And we know that there's more and more data out there to benchmark these outcomes. So I invite the physicians who are listening to come along for the ride, so to speak, because we're going to be helping people by doing this, I think. So, but thanks again for having me.
Oh, thank you. I appreciate it.
Thank you for joining us for this edition of POMA Does. Be sure to subscribe to POMA Does wherever you listen to your podcasts, and tell your friends and colleagues to tune in. Learn more about osteopathic medicine and POMA on our webpage, www.poma.org, and join the conversation on social media. We're on Facebook, Instagram, LinkedIn, Twitter, and YouTube. Or email us at poma@poma.org. We'd love to hear from you. Join us next time for another edition of POMA Does.